Assalamu alaikum. My name is Dr. Enan Arshad, and I am course director of internal medicine certificate program as well, and I am also secretary of Pakistan Society of Internal Medicine Karachi chapter. Also working as assistant professor in Department of Medicine. So, and I'm also associate program director of internal medicine residency program. I welcome all of you, and I'm very grateful to all of you for attending this course. And this is the first lecture of this course, and most of the internists have encountered the people who are with multiple medical problems. So, how we deal with holistic approach to a patient with multiple medical problem. So this is important, and this is the thing that this is not new for any of our internist or family physician or general practitioner. It's not new for any one of us, but how we need to integrate is important. So in next few minutes, we will see how we have to behave. We have to behave when we see that. So I will start my talk with a case of 74-year-old lady who presented to you, your OPD with generalized weakness and generalized and decreased oral intake for 1 week. For inquiring the past medical history, she is having hypertension. She's taking losartan potassium for this hypertension. She is diabetic, taking metformin for it. Coronary artery disease, status post percutaneous coronary intervention to left anterior descending artery for 2 years back, and she is taking aspirin, carvedilol, and atorvastatin. She's also having overactive bladder. She's on Foley's catheter for 2 years, and she's having depression. She's on Sertraline. So we can see the diversity of medical problems that this 74-year lady is having. That she is diabetic, she's hypertensive, she's had one MI for that, she had angiography. She's also having overactive bladder. She's taking Foley's catheter, and she's depressed, taking Sertraline. Her vitals are 100 by 55 blood pressures, heart rate is 60, respiratory rate is fine, saturation is 94% on room air. On examination, GCS was 14 by 15 with no focal deficits. On neurological examination, chest is normal, having normal vesicular breathing. First and second heart sounds are audible, and abdomen is soft and non-tender with no abnormality in sounds. So you advised baseline labs and serum sodium came out to be 114. So it's not about what is the diagnosis this time. It's what about how you will manage this patient and select therapy that will not interfere with other medical condition comorbidities that this patient has. So if we remember, we need to correct the sodium of this patient, this 74-year-old. So first, we have to see that she is on losartan potassium already, and it also causes hyponatremia. Though she is taking for years or not, that we need to inquire more in history. Is it a recent change in medication or it's old change in medicine? And then if we stop that medication, how will about we do about that hypertension? What about the coronary artery disease? So she is also having overactive bladder on Foley's catheter. She might be having coexisting urinary tract infection along with that because she is on long-term catheterization. She is also on depression, on sertraline for depression. So there may be some association of sertraline with hyponatremia. So we need to deal with these things. So these are sort of patients that we see mostly in our acute care setups in the various tertiary care hospitals. So a panel governed by the American Geriatric Society has identified 5 guiding principles for management of multimorbidity, elicit and incorporate patient preferences to medical decision making. So we have different setup in Pakistan, but in America, in UK, in Canada, everywhere the patient has, which is the patient's own right, the patient's autonomy. That patient has the right to decide about his own treatment, what we need to treat, what we don't need to treat. It's all about the patient's own wish, what he or she wants. So recognize the limitation of the evidence base in interpreting and applying the medical literature to persons with multiple morbidity, and remember evidence base is more and more important. From clinical management decision within the context of risk, burden, benefits, prognosis, remain the life expectancy and functional status and quality of life of patient. So we need to take care of, for example, we have 80-year-old lady with some need that can be surgically corrected, but having underlying medical problem. For that, we can probably correct that medical problem, but other cancer or anything metastatic disease may already uh, threatening for the patient. So we have to take care of it. That is our treatment really helpful for that patient or not? If it's helpful, we should definitely do it. But if it's not helpful, you know. Similar case can be if we can have a lady or a gentleman with even if 80-year or 90-year, but no prior comorbid and just a femur fracture, and now he or she is bedbound. So after that, if we can do that surgery and the patient's functional status can be improved after that surgery, so definitely we should do it. But if he or she is having already a stroke and he was bed bound and he was just fell from the bed and had a fracture, so repair of that fracture cannot be very fruitful for that patient. So risk benefit, burden, prognosis, life expectancy, functional status, and quality of life is important. Consider treatment complexity and feasibility when making clinical management decision, and choose therapies that optimize benefit, minimize harm, and enhance the quality of life. So these are the 5 principles that they gave us. And the American Geriatric Society also advised the following approach for patients with more than 10 years of life expectancy, few chronic condition, and none or few functional limitation. Disease-specific guidelines should be utilized in accordance with the patient preferences. तो 10 साल से ज्यादा की लाइफ एक्सपेक्टेंसी है, हमें पता है कि ये 10 ईयर से ज्यादा सरवाइव कर सकते हैं। क्रॉनिक कंडीशन बहुत मामूली सी कोई डायबिटीज या हाइपरटेंशन है जो वेल कंट्रोल्ड है, एंड कोई फंक्शन लिमिटेशन हल्की फुल्की है, बहुत ज्यादा है कि चलो ड्राइव नहीं कर सकते लेकिन चल फिर सकते, अपने काम कर सकते हैं। इसमें हमारे लिए जरूरी है कि हम डिजीज स्पेसिफिक गाइडलाइन जो है हम उसको फॉलो करें। बट फॉर द पेशेंट with less than 1 to 2 year of life expectancy, हमें पता है कि 1 से 2 साल से ज्यादा है नहीं, with an advanced disease, guideline specific care to aggressively treat and manage disease often not best aligned with the patient goals and preferences. Rather, care should be focused on aggressive palliation of symptom and care plan that would prioritize quality over quantity of life. So फिर हमें ये देखना है कि हम किस तरीके से, अगर मरीज का हमें पता है 1 से 2 साल भी बमुश्किल मौजूद है और कंडीशंस काफी खराब है, तबीयत वैसे ही खराब है, ऑलरेडी बेचारे की मिजरी है, तो हमें फिर बहुत ज्यादा एग्रेसिव जाके इंटरवेंशन नहीं करनी है कि हम डायलिसिस पे जा रहे हैं, हम एंजियोप्लास्टी कर रहे हैं, हम एमआईएस को फिक्स कर रहे हैं, हम फ्रैक्चर्स को फिक्स कर रहे हैं, हम सर्जरीज कर रहे हैं. Then we have to go on the palliative intent and we need to understand ourselves first, and then we need to take patient and the families on board, उनको बिठा के समझाएं और उनको बताएं कि देखिए ये इलाज इनका इतना इम्पोर्टेंट है और इतना इम्पोर्टेंट नहीं है. मेडिसिन का जो उसूल है वो यही है कि ऑटोनॉमी है सबसे पहले और उसके बाद बेनिफिशंस, यानी पेशेंट के फायदे में, देन नॉन बेनिफिशंस यानी डू नो हार्म. हमें कोई भी ऐसा काम नहीं करना जिससे मरीज को नुकसान पहुंचे. ठीक है, सो ये हमें भी अंडरस्टैंड करना है, हमें फैमिलीज को भी अंडरस्टैंड करना है. रिमेंबर, इफ वी डोंट अंडरस्टैंड दिस फैक्ट, वी विल नॉट बी एबल टू मेक आवर फैमिलीज अंडरस्टैंड दैट व्हाट इज राइट और व्हाट इज रॉन्ग. वो तो यही कहेंगे आपसे कि हार्ट अटैक है डॉक्टर साहब, आप हार्ट अटैक को सही करें एंजियोग्राफी. उनको नहीं पता होगा कि किडनी फंक्शन खराब है, इसमें पेशेंट डायलिसिस पे जा सकता है, कितने फायदेमंद चीजें कितने फायदेमंद नहीं है. तो साइड इफेक्ट, risk, benefit, we need to understand everything ourselves. We need to refresh ourselves, and that is the reason of attending these courses. So for the patient with 2 to 10 years of life expectancy and an increasing number of severity of chronic condition and functional impairment, multiple chronic condition, action steps should be utilized. So elicit patient goals and priorities, discussion, end of life preferences. Discussing This decision making to include drug initiation and discontinuation, कौन सी दवा शुरू करनी है, कौन सी बंद करनी है, hospitalization and procedures and recommendations for behavioral change such as dietary restrictions. डायबिटीज का पेशेंट है, सो हमें उससे आम खाने के लिए नहीं कहना होगा कि भाई आप आम खाइए। ओके डॉक्टर साहब, मैं फुल परहेज करता हूँ, मैं बहुत परहेज करता हूँ डॉक्टर साहब, मैं कोई भी चीज नहीं ले रहा हूँ, जैसे आपने बताया। हाँ बस आम का मौसम है डॉक्टर साहब, एक आम खा लिया तो क्या हो गया, कौन सी क़यामत आ। सो दिस इज द थिंग कि उससे क़यामत यही आई कि HbA1c लेवल जो है वो बढ़ गया, शुगर अनकंट्रोल हो गई, किडनी फंक्शन खराब हो गया, जो दवाइयां हम दे रहे रीनल एडजस्टमेंट उनकी खराब हो गई। घर में कौन क्रिएटिन अपना रोज चेक करता है, कितने लोग हमारे हेल्थ केयर को सीख रहे हैं। So this is important. So it's also important to know the successful elicitation of patient preference required that patient and provider communicate effectively and that patient has an adequate understanding of relevant choices and their expected outcome. हमारे सेटअप में ज्यादा मुश्किल इसलिए हो जाता है because we need to communicate everything to the patient and then to the family member as well. क्योंकि family member or the caretaker, they should, because this is not West where the patient is himself taking care of himself. So we need to depend on the families, the kids, the sons, the daughters, the wives. तो जो भी उनकी केयर टेक कर रहा है उनको भी समझाना है, तो इफेक्टिव कम्युनिकेशन बहुत जरूरी है, बहुत सारे मसाइल वहां पे हल होते हैं। Coordination of care is important. Like frequent clinical encounters often multiple providers representing different discipline across many healthcare settings. Outpatient में आ रहा है, कोई inpatient है, फिर emergency है, long term और rehabilitation facilities in home care. ये 5 किस्म की हमारी facilities होती है where we have to see. Then a transition of care have been identified as high risk opportunities for medical errors, particularly for complex medical patients. Inconsistent recommendation or duplicative care from various providers can result in patient confusion, unnecessary cost, and treatment burden resulting in poor quality of care. एक पेशेंट की डायबिटीज इंटर्निस्ट भी देख रहा है, एक पेशेंट की डायबिटीज एंडोक्राइनोलॉजिस्ट भी देख रहा है, एक पेशेंट की डायबिटीज फैमिली फिजिशियन भी देख रहा है, तो आई थिंक इट्स नॉट जस्टिफाइड फॉर द पेशेंट। अगर इसकी डायबिटीज कंट्रोलेबल है, इजी टू मैनेज है, तो फैमिली फिजिशियन और इंटर्निस्ट should manage it and should not refer this patient to endocrinologist. But yes, if the patient is having uncontrolled diabetes and that is not being managed adequately by ourselves, then we should refer that patient to endocrinologist to seek their help. But we should, I strongly request all of us that we should not right away refer all the patients of diabetes, simple diabetes, to endocrinologist, because the internist should or family physician should manage simple diabetes. Otherwise, I think it will not be good for patient to pay to 2 or 3 people for just simple diabetes that can be adequately managed by simple medication, and patient have to pay all this out of their pocket. So we have to take care of this as well. An essential component of high quality of care for patient with multi-morbidity is coordination of uniform care plan that is communicated across setting, providers and caregiver. सबका एक टीम होना चाहिए और साथ टीम मिलके। So the way forward is multidisciplinary forums such as tumor boards or stroke teams, electronic health records, integrated care. So electronic health record facilitate access to sharing of information between various providers, and it will help in research as well. The centers where electronic health record are already here, so they use it for their research as well, and that research can be fruitful for the patients. Multidisciplinary forums such as tumor boards, stroke teams provide regular opportunities for discussion of patients with multiple providers involved in certain aspects of patient care. And integrated care involving both psychiatric and medical specialty providers address the medical condition in depression that frequently coexisted in older patients. So less may be best. Every intervention, hospitalization or medication prescribed creates the potential for harm. The risks are magnified in patients with multiple morbidity. तो यहाँ पर ज़्यादा बढ़ जाते हैं, multiply हो जाता है risk factor. So वो आपको बताना होगा patients को और families को. Treatment goals, careful consideration should be given to each treatment decision and how it figures into patient preferences and overall equation of potential benefit. versus burden and risk. Medication consideration in elderly population: start low, go slow with any medication initiation or dose change. Don't jump into multiple medications for some, because polypharmacy is again proved as has been proved as risk of fall and multiple side effects. So always ask, can this problem or symptom be addressed without my prescription pad? For example, could reflux be addressed with dietary changes and elevation of head of the bed? So हम वहीं पे पहुंच गए जहां पे हमारे सीनियर्स हमें बताते थे कि पहले कंजर्वेटिव चलने की कोशिश करें। आज एविडेंस वही कह रहा है कि सबसे पहले कोशिश कीजिए कि क्या हम उसको विदाउट किसी मेडिकेशन सही कर सकते हैं, उसकी लाइफ स्टाइल को सही करें, हम प्राइमरी प्रिवेंशन पे काम करें कि शुगर हुई ना, अगर किसी की फैमिली हिस्ट्री है तो हम उसको पहले ही बताएं कि जरा मीठे पे कम हल्का हाथ रखिए, ठीक है, और रेगुलर अपने चेकअप्स करते रहे, स्क्रीन करते रहे, और अगर फिर भी निकल आए तो फिर अरे उसको वी हैव टू ट्रीट. So as conservative as possible, frequent review of medication list for appropriateness in the context of patient's goals and preferences, with consideration of de-prescribing as necessary. एक पेशेंट कह रहा है डॉक्टर साहब मुझे इंसुलिन नहीं चाहिए, why we are prescribing insulin? We have oral hypoglycemic agents, so we try to give oral hypoglycemic agent और उससे ही काम चलाया जाए. But if there is a need of insulin, then we need to counsel कि सर अभी आपका काम नहीं चल रहा है इससे. Now we need to have start insulin. क्यों इंसुलिन देनी है? क्योंकि शुगर कंट्रोल करनी है. शुगर कंट्रोल नहीं हुई तो क्या हुआ? तो ये होगा कि फिर शुगर तो नहीं मारती, लेकिन शुगर की जो कॉम्प्लिकेशन है, जो मैक्रोवास्कुलर माइक्रोवास्कुलर कॉम्प्लिकेशन है, that can cause disability, that can harm your quality of life. आप बेड बाउंड हो जाएंगे, खुदा ना खास्ता स्ट्रोक हो गया तो, हार्ट अटैक हो गया, लाइफ थ्रेटनिंग हो सकता है, आंखों की बीनाई जा सकती है, हाथों पैरों में सनसनाहट हो सकती है, हाथों पैरों में चप्पल उतर जाएगी, इन्फेक्शन हो जाएगा, टांग काटनी पड़ जाएगी, इस किस्म की चीजें. So we need to discuss these things with our patients with on very humble and polite note. उनको समझाना होगा ताकि वो खुद अंडरस्टैंड करें, खुद कहें डॉक्टर साहब आप सही कह रहे हैं, आई थिंक मुझे इंसुलिन ले लेनी चाहिए. लेट्स गिव देम चांस कि 3 मंथ्स के लिए इंसुलिन ले लीजिए. 3 मंथ्स में हम आपका HbA1c रिपीट करेंगे, हम आपकी शुगर को दोबारा असिस्ट करेंगे, अच्छा सा कंट्रोल कर लीजिए, 3 महीने कर लीजिए, उसके बाद उसको वैसी हैबिट बन जाएगी. So consolidate drug dosing schedules to minimize complexity and chance of error. Consolidate treatment when possible, ACE inhibitor for blood pressure, renal protection, heart failure. जबरदस्त दवा है, एक दवाई से आपके सारे काम हो रहे हैं, but cautious in renal failure. So identify and address issues that impact multiple conditions. This is important. Try to make your checklist when you see the patient: nutrition, physical activity and exercise, function independence, sleep disturbance, mental health, safety of environment and adequacy of support in current level of care and caregiver stress. And try to document these things in your prescription as well. That walk कीजिए, 20 to 30 minute walk, 5 days a week, 5 days a week. Okay, so this is all guideline. The guidelines say this, and you just document this in your prescription. Stop smoking, reduce the amount of alcohol to the daily recommended doses. Okay, so these are the things that should be mentioned in our prescriptions. Common disease specific consideration: that guideline principle patient multiple morbidity should be individualization of treatment. Like diabetes, appropriate target of HbA1c should be individualized based on life expectancy and comorbidity burden. Target of 8% is appropriate in person with limited life expectancy or person in whom the risk of hypoglycemia outweigh the benefit of aggressive targets. For example, person who have difficulty in maintaining consistent caloric intake due to GI comorbidities or condition that cause frequent nausea or anorexia. आप उल्टी मसली हो रही है, खाना नहीं खा पा रहा है, उसका HbA1c हम 6 पे या 5 पे रखेंगे तो बेचारा वैसी हाइपोग्लाइसीमिया हो जाएगा उनको. सो हमें कोशिश करना है उनका HbA1c 8 के आसपास रखें. Further, American College of Physicians recommend avoiding the target HbA1c level altogether in patient with life expectancy less than 10 years and treating only to minimize symptoms. The risk of hypoglycemia is increased in older adults, particularly those with comorbidity. Thus, when possible, therapeutic agents should be selected that have lower risk for hypoglycemia. We can give metformin, We can give sitagliptin, we can give vildagliptin, shorter acting sulfonylurea or rifenylide. Hypertension, a less aggressive systolic blood pressure goal may be appropriate for patients with limited life expectancy. Comorbidity should guide choice of agent. Goal is avoid accelerating comorbid condition. So drug examples, beta blockers, we cannot give in reactive airway symptoms. They may be bad because of that. और sexual dysfunction कर सकता है males के अंदर. Diuretics, urinary incontinence, बहुत ज़्यादा diuretics है, तो avoid करें उसको भी. So beta blocker भी avoid कर लिया हमने और diuretic भी. And minimize polypharmacy. Hypertension, BPH, try to give one medicine. Alpha blocker, doxazosin, Cadura. So this was my last slide, and with this, I am thankful to all of you for attending this course and this session, and I'm grateful to all of my team for supporting and organizing this whole certificate course. So thank you so much, and for any query, you guys can email us so that we can. The discussion forum is open for 1 week, and we can discuss these things on that discussion. Thank you so much. Allah Hafiz.